VVA, the sexual problem, and the urinary problem. So now we have the GSM, genitourinary syndrome of menopause. Let's review the main symptoms. For the VVA, for sure you know vaginal dryness, the most important point. Irritation, burning, itching, leukorrhea, dyspareunia by stenosis of introitus or atrophy, vaginal or pelvic pain, and pressure, vaginal vault prolapse. And for sure, for sexual problem, you will have dyspareunia, reduced lubrication, postcoital bleeding, and all these symptoms leading to decreased arousal, orgasm, and desire. For the urinary component, you will have a dysuria, urgency, stress, or urgency incontinence, recurrent urinary tract infection, urethral prolapse, ischemia, or vesical trigone. In a cross-sectional study of 430 postmenopausal women in Spain, you can see that it's very frequent, even very early postmenopausal. In the less than 5 years, you have more than 59% of people complaining of vaginal dryness. And if you are more than 5 years, it's 73%. So it's very frequent. Dyspareunia, the same. Irritation and burning is less, a bit less. And you can see that urinary urgency and frequency are very high, 66%, even at very early in the menopause or late in the menopause. And for sure that it's persistent. It's telling you that when it's coming, it will persist for the time going. So you have to recognize also the signs of at the vulva. You can see the reduced pubis mons and labia majora bulk, a resorption of the labia minora. So very often they will refer us, the family physician will refer us for lichen sclerosis, but it's just a natural process of resorption. You will have the retraction of the introitus, loss of hymenal remains, stricture of hymenal ring. We can see that very often now with the people not having delivery by the vagina with C-section, or people not having a pregnancy before. And we can have also prominence of the urethral meatus, urethral eversion and prolapse. And in the vagina, we will see very easily the fragility, fissure, and petechiae, lots of vaginal fornix and vaginal rugae, decreased elasticity, decrease in vaginal length, and you will, for sure, you will observe yellowish and brownish leukorrhea. So it's easy to do. A diagnostic of GSM is require only the presence of characteristic examination for signs and to look for the bothersome symptoms. And you don't have no other test required to confirm diagnosis. It's clinically done. So what is it important to talk about the pathophysiology? I think that is the most important point. We treat with estrogen since 50 years, a long time, estrogen in the vagina with the Primarine cream, the oldest product that we have. And we started to treat that, and it's very efficient. But do you know that androgen is also needed? Do we know that? I'm not sure. So let's review the histology of the vagina. First of all, we have 3 layers: the epithelium, the lamina propria, and the muscularis. I will insist on lamina propria. I think that is the most important layer of the vagina. It will contain the vessel, the collagen fibers for the strength, the elastin for elasticity. And for sure, remember there is no glands. So the lubrication comes from the vasodilatation of the vessel and the transudation of the water going through the layer to the vagina. We also have the axon with sympathetic, parasympathetic, and sensory system. So it's the communication with the brain, the most important point in the sexual response is responsible for the lubrication with the arousal. You have for sure muscularis, 2 smooth muscle layers, circular and longitudinal, and it's involuntary contraction, Women doesn't feel that during the orgasm, and nerves flow through the lamina propria and muscularis. In the epithelium, we don't have any vessel, we don't have any nerves. So here is my patient, in the first two in the left, the epithelium, you can see that is a 42 years old patient, not menopause. You can see the rete that ensure the communication with the lamina propria, increase the surface to the basement membrane. You can see the lamina propria full of the vessel and collagen, very strong collagen. And you can see the muscularis. The muscularis was done in a corpse, in autopsy of a 21 years old. And the other side is an epithelium of it's a 67-year-old in autopsy. You can see the flat epithelium. You can see that the lamina propria does not contain any more vessel. It's no more, and the collagen is less, and the muscularis is disappear. So what do you know about the estrogen receptor? For sure, they are present in the epidermis and dermis of the labia minora and the 3-layer of the vaginal mucosa. It's a role in the blood vessel development, thickness of the vaginal epithelium, and ER are more important in the vagina than in the vulva. You have to understand that. Clinical effect of estrogen on vaginal tissue of postmenopausal women. For sure that we have a positive effect of vaginal epithelium, the microbiota with presence of coming back of lactobacilli, creating the acidic pH. We have the vaginal secretion. We have an effect also on pelvic collagen metabolism. It was studied by Jackson a long time ago. And he gave to the patient estrogen, local estrogen, but unfortunately stimulating the collagen degradation via increased proteinase activities. It's not what we want to have. And we have no effect on estrogen on nerve ending in lamina propria, proved by Gribling in 2012. What about the androgen receptor? Androgen receptor are greater than estrogen receptor in the vestibule, labia minora, labia majora, and clitoris. And remember that it will decline with age. So it's an important role of androgen in this area, mainly on the vulva. Effect on androgen on vaginal tissue, what do we know? We have only animal studies, thickening of vaginal epithelium, density of collagen fiber and thickness of lamina propria. So it increases the collagen fibers and thickness of the lamina propria. It increases the density of nerves and stimulation of the third core, the third muscle layer. And remember that in a study by Trash, in a rat, it was an important role in modulating the physiology of the vagina to improvement of genital sexual arousal. And in women, what do we have? We have only a positive effect of vaginal epithelium with DHEA. You know that Intrarosa was on the market, and they proved that they have an effect on the epithelium. That's it that we know for the women. So I did, in my patient, I did the receptor, and yeah, we can see in green, the vagina with estrogen receptor, mostly in the epithelium. And you can see in the vestibule that we don't have a lot of receptor. The black dot are not anymore present, only in the basement membrane. You can see in the red at the bottom, the vagina will contain less androgen receptor in the epithelium than estrogen, but you can see that at the vestibule, they are more present than the estrogen. So it's an important component of the vestibule, maybe for the pain also in the vestibule. So I did a clinical research with the collaboration of Alain Dury. It's the result of a small trial in my patient, in postmenopausal patient, on the effect of progesterone on lamina propria. And I want to share my result with you. The trial objective was to characterize the histological change associated with the relief of symptoms of VVA by intravaginal progesterone. I recruited the 6 subjects and to isolate the androgenic component by excluding estrogenic benefit with aromatase inhibitor patient. 2 patients with breast cancer taking aromatase inhibitor, so to be sure that we isolate the androgenic component of the progesterone. And we administered, we did an administration of progesterone for 12 weeks. We did vulvoscopy, and we did vaginal biopsy, assay of the collagen, and particularly the patient with aromatase inhibitor, the large effect. Here, the elastin, so it's a new thing. We have a coming back of elastin, mainly concentrate just below the basement membrane, and we have an increase of 36% of patients in the group A without aromatase inhibitor, and we have one patient on 2 having an increase of 21%. So we have a response of the half in the aromatase inhibitor. But let's go to see the effect of nerve density. What do we use to see the nerve density? We use the synapsin, immunohistochemistry of synapsin. That is a marker in the synapse of the nerves and in the vagina. So with the arrow, we can see that we have an increase of 152% of the nerve density, and it was also present with the patient with aromatase inhibitor, 78%. So we have a coming back of the nerve density that it was proven in the women, that was also proven in animals. So we were very happy to see that. And we calculate also to see the effect on the neuronal synthase. We can see that we have nitrous oxide synthase immunohistochemistry. We have 111% average increase compared to 516 in the group with an aromatase inhibitor, and we were very satisfied with this result. What about the vulvoscopy? To the right, to the left is patient without aromatase inhibitor. To the right is the 2 patients that we have in the study. We can see a diminution of the redness. Elasticity was much better. And the patient of the lowest cases at the right was unable to have penetrative sex. And after 12 weeks, she was very happy she has penetrative sex. It's a patient that I was talking about with the immunal ring, the fibrosis of immunal ring that maybe restrain the penetrative sex. So what does this mean clinically? So increase elastin fiber, improve elasticity for sexual comfort. Nitrous oxide increase the cyclical guanosine monophosphate responsible for the relaxation of smooth muscle of vessel, the same effect as Viagra. It increase the genital vasoconstriction and production of plasma transsudate in the vagina, meaning lubrication, increased lubrication. And the nerve ending increase the sensation and communication with the brain with a better response to the vagina to stimulus. So at the end, in my conclusion and take-home messages, GSM symptoms are experienced by most postmenopausal women. In general, GSM persists indefinitely and worsen over time without treatment, with a destruction of specific structure of the vagina. It's difficult to the coming back of the structure. Understanding underlying pathophysiology of the role of androgen and estrogen will help us to understand new therapeutic strategy, maybe combine estrogen and androgen, or use just androgen or just use estrogen. And long-term therapy should be considered for GSM. Thank you very much for your
All right, thank you, Professor Bouchard, for that talk. We'll conduct the questions at the end for your talk, and we're going to move on to Dr. Premitha Damodaran, who is coming to us from Malaysia. It's around 9 p.m., I think, where she's at. So a big thanks to her for sharing her talk with us today on management of GSM this evening. Thank you. You can go ahead.
Thank you. Let me just start by sharing my slides. So you can see my slides now? Yeah. Yes, thank you. Again, thank you. Hello, everyone. It is 9 p.m. in Kuala Lumpur. It's about 9:20 in Kuala Lumpur, Malaysia. And I would really like to thank Professor Celine Bouchard for that excellent talk, because it just sort of set the stage for what I am going to talk about, a patient-centered approach to how do we deal with women who come to us with GSM problems. I have no conflicts of interest to mention out here. Now, it was only today, and I actually had one patient that came in today, and her first sentence to me in the clinic was to say that I no longer recognize how I feel as a woman, because she was suffering with vaginal dryness and pain. And I just thought that, you know, this is the way to start today's lecture, because of the fact that GSM actually requires a very holistic approach in how we manage our patients, because genitourinary syndrome of menopause impacts physical health, emotional well-being, definitely sexual function, interpersonal relationship, and overall, it affects our quality of life as a woman. Now, I always tell my students this, that when you start that conversation about GSM, please do not think that it is only a problem for sexually active women, and do not ignore that woman who is not sexually active, because all women can suffer from GSM, and we have to help all these women. And it is all about taking a proper history, because it's just not all about menstrual history or what kind of symptoms. That just forms the base. But it's all about taking other essential history, like what kind of medication she's on, allergy, cold medication, antidepressants, whether she's a smoker, whether she's gone through cancer treatment, whether she's just stressed, lifestyle, and the type of exercises that she does. And I usually don't like the triangular seat of the cycle, tight clothing, whether she's been on any form of hormonal treatment, any GnRH agonist. Let's not forget the older woman who would have gone through childbirth and then gone into menopause, and anyone with Sjogren's syndrome. So these are very important factors that we have to take into consideration when we are treating our women. It is so important to do that physical examination. And as Professor Bouchard mentioned, it is very distinctive. And what we are also looking out for is to rule out other pathological conditions, any other vulvovaginal conditions that can actually cause symptoms. It is so important to be gentle. Very, very important. And sometimes, especially when I am explaining about what they do have, is the fact that I actually bring in a mirror to actually show them that these are the areas that they should concentrate on, and where do they put their creams or lubricants, just to help them through that, to help them ease them through that pain. So very important to do a gentle pelvic examination. Prof. Bouchard again has gone through what we look out for, looking at the moisture content, the loss of the urethral angle, loss of rugae, the loss of that vulva fullness, labial fullness, the pallor, which is so distinctive, and sometimes it can also make us feel the pain that that woman is going through, the shortening, the narrowing of the introitus, the loss of the elasticity. So it's really very important to examine that woman properly. Now let's just go through two case histories, just to run through what we would normally see with our patients and how do we then manage them. Now let's look at Paula. She's 55. She's been in the menopause for 2 years, coming in complaining about severe itching, burning sensation. She's been typically treated with antifungals, antihistamines. She's gone on antibiotics for UTI. She's getting desperate because sex has become very painful. And when you examine her, you see all the typical symptoms, along with scratch marks over the area, and everything is so painful and very, very tender. So what are the treatment goals? The treatment goals are the fact that you need to take away those symptoms. You need to restore the urogenital physiology and you need to improve Paula's quality of life. But at the same time, we need to talk to her about what she would like and what are her personal preferences. Go through all this with Paula. So lifestyle modifications consist of, is she a smoker? Stop smoking, cut down the caffeine. If she's overweight, please reduce some weight, because even a 5-kilo drop in weight would help with GSM issues. Activity modifications, we know it's very easy for us to tell her you need to have sex, but of course it is very, very difficult. But we hope that as she gets more comfortable with the treatment that we are giving her, she then practices regular intercourse, and that itself would help with the problems of GSM. She also can use self-stimulators, dilators, and of course, reverse pelvic floor, pelvic exercises, which would also help relax the muscles and allow her to have sex comfortably. Now, what do I consider vaginal health 101? And I'm not sure about women elsewhere, but we do know that in Asia, being very clean is really very important. So a lot of women actually use excessive hot water, harsh soaps, cleansing agents, perfumed soaps, just to keep them smelling good. A lot of douching that actually comes in. And all this is actually a no-no. We teach them about pad hygiene. Do they really need to use panty liners? After exercise regimes to aerate the area. No need to wear an underwear if you don't need to, what are the options? Waxing, trimming, what would make them feel more comfortable and allow that skin around that area to actually heal. Non-hormonal therapy would actually consist of that would be the first line therapy. We are looking at the oils and creams. A lot of my women actually use virgin coconut oil. We also have the vaginal lubricants, the moisturizers, and of course, the topical anesthetics. So lubricants, basically just before sex, very short-term relief, basically for mild to moderate vaginal dryness. There are different lubricants in the market. We are looking at the water-based, silicone-based, oil-based, and it's always very important to get that lubricant that suits you. So that woman may have to go through a bit of a trial and error area to get to that lubricant that she feels comfortable with. Moisturizers, I would say, is one step higher. You don't have to use it just for sex. It is only used 2 to 3 times a week. Most moisturizers nowadays actually contain hyaluronic acid, which actually helps rehydrate, keep that moisture locked in. And very importantly, moisturizers can be used actually independent of sexual activity. And again, has shown a good results with mild to moderate vaginal dryness. Topical lidocaine, numbing that area. And I always talk to my patients of the fact that if you are going to use lidocaine, then remember that the partner should wear a condom to prevent any numbing of the penis. And that's really very, very important. Now, vaginal estrogens, which is the gold standard treatment for women with GSM symptoms. Whenever a woman has only GSM symptoms, we offer them vaginal estrogens. They are not to be given systemic hormone therapy in the absence of any other menopausal symptoms. And women do not have to have concurrent use of progesterone for endometrial protection if they go on only vaginal estrogen, because we know from a lot of data out there that it does not increase the endometrial thickness. We have different types of vaginal estrogens. There are creams, there are rings, there are tablets, there are soft gels. It all depends on which part of the world that you are in and what is available there. In my country here, we have the conjugated equine estrogen, and we have other estrogens that are combined with probiotics. So we are at a loss of, we don't have the ring or the tablets, which would help our women much, much better. So it all depends on what is available in your part of the country. But having this choice of, with us actually helps find that right vaginal estrogen for that woman. It is very important that the vaginal estrogen, except for the ring, which is put in higher, the vaginal tablets, the vaginal cream should be inserted in the proximal lower third of the vagina rather than in the upper third, because this actually improves efficacy for genitourinary symptoms and attenuates the estradiol absorption. So this is really very important. They don't have to go all the way in. Unfortunately, most and all, or rather, of all the low-dose vaginal estrogens carry that FDA warning, and this actually scares women, because I'm sure it's not only me, and I'm sure it happens to you, that a lot of women get worried with this black box warning, saying that estrogens would give cardiovascular, cancer, or endometrial hyperplasia risk. And I hope that in the next decade or so, this actually goes off, and this would actually help our women much more. I'm not going to talk to you so much about vaginal DHEA because the previous speaker has gone through it very beautifully, but it is indicated for moderate to severe dyspareunia converted by the vaginal mucosal cells into estradiol and androgens, which actually improve that integrity of the vaginal epithelium, increasing that lubrication, enhances elasticity, restores sexual function without actually increasing systemic levels. So great for moderate to severe dyspareunia. It's just one ovule that is inserted every night into the vulva. The only side effect could be from the fact that there is melting of that hard fat of the ovule, and so the woman can actually have some vaginal discharge, which might get irritated with. But it is an expensive agent, and that's why not to be used as first line, unless, of course, covered by the public costs. And it's usually used as a second line option when the non-hormonals and the vaginal estrogen does not actually work. Ospemifene was coming to Malaysia at one point, and then it went away. It is the only oral tablet available for treatment of moderate to severe dyspareunia. And I think this is really very important because some women do not want to put anything down there. They do not feel comfortable with creams, tablets, rings, and they may actually prefer an oral tablet to help them with treatment of moderate to severe dyspareunia. It is a selective estrogen receptor modulator. It is an agonist to the vagina and endometrium and an antagonist to the breast. There are risk of hot flushes, sweating, and muscle spasms. And this ospemifene does carry a box warning of increased risk of endometrial cancer and cardiovascular disease, which may again be a scare for women who want to go on an oral tablet for vaginal dryness. Now, vaginal laser therapy, again, a very expensive therapy. Women would need to do 3 sessions at intervals of 4 to 6 weekly. It improves blood flow with new collagen formation, but it needs to be repeated 18 months, 24 months. It also needs logistics, instrumentation with heavy costs. Many insurances do not cover vaginal laser therapy, and it becomes out of pocket for that particular woman. And again, current evidence is the fact that current evidence is insufficient to support its routine clinical use, and we need ongoing research and well-designed trials to establish its safety and efficacy. So let's go back to Paula now. What can you offer her? So you would start her off with lifestyle modifications, talk to her about Vaginal Health 101, talk to her about non-hormonal therapy. Vaginal estrogen becomes her first-line therapy. Ospemifene, vaginal DHEA can be second line. And if all else fails, or if there is a trial going around in where you are, then you can afford to give her or try her out on laser therapy. Let's go to the next very, very important case, who is Amy. She's 42 years old, a para-1, stage 2 breast cancer, ER/PR positive, presently on tamoxifen. Her period stopped with adjuvant chemotherapy. She now has got severe dryness in the vagina, constant burning sensation, frequent UTI-like symptoms. She's unable to exercise due to the pain, and she has, when you examine her, all the typical signs that you would get with GSM. Now, Amy is really very important because of the fact that you need to give her that quality of life. Now, when we look at adjuvant breast cancer treatment, we know that aromatase inhibitors are likely to make GSM symptoms worse, and tamoxifen is less linked with any breast cancer specific mortality. And another study that came out that looked into a meta-analysis of 8 studies in over 24,000 patients, again showing no increased recurrence risk and no increase in all-cause or cancer-specific mortality. So all very good news about vaginal estrogens and breast cancer. It is really important, but it is still a shared decision-making between the patient, yourself as a gynecologist, the oncologist, because everyone has to be on the same page in giving her that vaginal estrogen. Because for that woman, it would be still estrogen, and she may be still worried about the fact that even though we tell her repeatedly there is no increase in systemic levels of estrogen, she may still be worried about it. So shared decision-making is very, very important. What about other treatment? Ospemifene has been approved by the European Society, but not the FDA for treatment of GSM symptoms, but only after completing all definitive treatments, including adjuvant endocrine therapy. So only after all that would you then offer her ospemifene. Vaginal DHEA approved by both FDA and EMA for managing GSM, but the data sheets still include a cautionary warning regarding use in breast cancer patients. Laser may be offered within clinical trial settings or when all therapies fail and after thorough counseling. So we go back to Amy, and then we talk about, again, the lifestyle modifications, vaginal health 101, basically a lot of non-hormonal therapy, which becomes your first line. Vaginal estrogen becomes your second line, and we, again, shared decision-making. And if all else fails, then you go on to the ospemifene, vaginal DHEA, or using laser therapy for the last. Now, this is the way I would look at it. Again, it would also depend on the guidelines in respective countries, how this changes. But again, for a breast cancer patient, I need to insist that a multidisciplinary team management is really very crucial. Now, it is always very important to schedule a follow-up appointment, ideally in about 3 months, address compliance concerns. If there is no response, we need to talk about altering doses, altering frequency of the products, changing brands, combining treatments, adding hormonal with non-hormonal therapy, and always asking the patient what would she like, even for an oral tablet. We need to emphasize compliance and continuation of therapy, and any abnormal vaginal bleeding should always be investigated. And this is, again, very, very important because GSM is a progressive disease. It only gets worse with time. And if menopause is around 50 and life expectancy now is approaching 80 and 90, she has got many years to suffer with that GSM issues. Thank you very much.
Excellent. Thank you very much for that talk. It was very engaging, and I appreciate you both for being here today. We do have a few questions from the audience, and I'll start with one for Dr. Bouchard. This question is, are there established recommendations or clinical guidelines for the use of prasterone, testosterone, or a low-dose estrogen in women following breast cancer treatment, and then taking into account whether or not they're receiving an aromatase inhibitor, as well as the hormone receptor status of the tumor? It's kind of a long question. Oh, I think you're on mute.
Sorry, I will say no, there is no guideline of that, but I will say that in the monography of the product of the HEA of Etrarosa, it's not a contraindication, it's a precaution in Canada, at least, for the breast cancer patients. So when you see the process of the HEA starting in the cell and coming out as conjugated estradiol is not anymore effective, you know, and it's not, so it's very safe, I will say safe. I will discuss that, you know, I'm in favor of prevention of GSM. It's not always talking about, so I'm not in favor of using lubricants. I'm not in favor of that because I want to preserve the vagina, the structure of the vagina, because when they are gone, it's gone. It's difficult to come back. So I will be more in favor of changing the practice of people to prevent this disease, because we see the patient much too late and it's permanent. It's mostly permanent, except that in my study, I can recuperate some elastin, some nerves, but the structure of the vagina, maybe it's too late to recuperate the function of the patient.
Yeah, I do agree with that. I think prevention is actually the key. I think that conversation about vaginal health should start from the very beginning. So many times when I'm catching the mothers, I always tell them, can you please tell your daughter this is what she should be doing? Because prevention is actually very important about how they are going to look after themselves for the future.
Unfortunately, we don't have any recommendation from the big society about prevention of the GSM. It's always treating the consequence of the disease, and it's a bit late. When you have a cystocele, colpocele prolapse, it's a bit late.
So a tack-on question from another attendee would be, would you recommend vaginal moisturizers for menstruating and perimenopausal women? I guess more so on the side of either symptomatic perimenopausal women or they're asymptomatic, but you're talking about prevention. Would you use moisturizers there? Would you consider more vaginal estrogen if you're seeing changes clinically?
So you're talking about a premenopausal woman here. So I would like to know, why is she having issues? And again, looking at lifestyle and seeing what's actually going on. If she's having dryness, if she's having pain, what's her lifestyle like? Is she a smoker? Cut down that smoking, cut down, you know, increasing coffee intake. What are the vaginal agents that she's using? I think we need to look into all that, because a lot of women are actually douching and doing a lot of other, I would say, unhealthy practices over the years, and that's actually then going to lead on to a lot of vaginal issues as they get older. So again, I wouldn't go straight into using lubricants. I would like to know why, what is actually happening. And of course, in that whole process is the fact that, has she got an STD? Is there anything else that's going on? That is also very, very important.
Dr. Bouchard, in which cases of GSM would you recommend treatment with prasterone as opposed to other options?
Because of my study and with the elastin increase, now I keep that for the women with the stenosis, you know, vaginal stenosis, because they don't have delivery by the vagina. So I keep that, and I have success. I'm surprised. I'm surprised myself, you know. I have success because they are more relaxed. We use the dilatator for sure. But with the prasterone, the elastin component of the lamina propria is coming back. So it's helped to have recuperate the function, the sexual function of the patient. So I will say the stenosis and the closeness of the vagina and the enteritis. And I would say also for the sexual function, increased orgasm. Then we have patients describing increased orgasm with the prasterone and in the fact, and when you see the nerve component of the lamina propria, that makes sense that we increase the orgasm because we increase the communication with the brain. We're not a vagina alone or brain alone. We have communication between. So it's increased the coming back of the nerve. I think that it's not enough study. Unfortunately, we don't have any study on the nerve component with estrogen. We don't have anything except the old study by Griblin.
Okay. And both of you have mentioned dilators. Can either of you speak to how you counsel a patient on use of dilators and how long, you know, how often do they have to do it? How long do they do this therapy? Maybe explain that a little more to the audience if they're not familiar with it.
Do you want to go? You want to start, Prof?
But for me, I will use a set of 5 dilator. They use the small one with lubricants. And as I said, it's not for masturbation. They can do that with masturbation, but it's more to insert and let it in the length and the vagina, let there for 15 minutes each day, and increase the volume of the dilator. I don't know your recipe, Dr. Damodaran. And
Well,
after 3-4 months.
I agree with you. With the smallest one, sometimes I find the women are very hesitant to even use that small dilator. Sometimes I give them lidocaine along with it just to make them feel more comfortable and gain that confidence level. Sometimes I get their partners involved, to help insert slowly. So again, making it a partnership kind of thing, and then slowly increasing it over a period of time. But I always find that first dilator is the most important one, because that's the one that they are really worried about. And when they get to the second and third size, they're actually feeling a little bit more comfortable.
Thank you. There's a question about vaginal laser as to whether or not it's painful. Could you speak on that a little, Dr. Damodaran?
Well, I've actually practiced vaginal laser for some of my patients. Actually, it's not. So what we do is we give them anesthetic first, a vaginal anesthetic. There is a cream that you can use. We leave it on for about half an hour, and then we try and then we use the laser. They are actually, it's not painful. I've had during the trial that I did, we've had women who they were watching movies while the procedure was going on. They are very hesitant in the beginning, and then they get used to the whole thing. But if they are in pain, I would not actually proceed, because I do not want to cause them more pain. So I would make sure that they're comfortable first, and then only go ahead.
I will add to that unfortunately, with the shame study, we don't have any effect at 12 months, and they are the same placebo or the group with laser. And I think that the effect of the first 3 months is the burning in the lamina propria. So the vessel are coming back, and because you have vessel, you feed the epithelium, and the epithelium is coming back by that. But after that, the vessel are coming down, and the epithelium coming down, and it's coming. He has to do again and again and again, and you will increase the collagen for sure, because it's like a scar, huh? So for sure, at let's say 5 years of that, twice a year, you will have sometimes the vagina will become maybe, I don't know.
Yeah, that's actually worrying. Long-term therapy is actually worrying, because you don't know what's going to happen with repeated vaginal lasers. Yeah, for the first time, the first few sessions may be okay. We need long-term data. We need properly conducted trials before we can actually endorse it.
Great, thank you. There's a question about, is there a role of vitamin D or probiotics for GSM?
Well, there's a lot of new data that's coming in about vitamin D and helping with genitourinary syndrome of menopause. And I would put it as, there is no harm if it works. But I think that particular study that showed that was actually using vaginal vitamin D tablets. And that's not easy to get. I don't have it anywhere, so it was a trial with vaginal vitamin D tablets. I do not think if you take oral vitamin D, it's going to help your vagina. And that's actually my thoughts about it. Now, probiotics, definitely, why not? Because when menopause kicks in, it just changes that pH there. And if just simple probiotics would help get that lactobacillus to come in and correct everything, it's actually a good thing.
When you know the mechanism of action of estrogen and androgen on the vagina, I don't see the role of vitamin D. When you know the pathophysiology of the vagina, it's an organ dependent of hormone, and we need hormone as estrogen or androgen, but it's an organ hormonodependent.
There's a question about tibolone. I know we don't use this in the US, but how about that as an option for healthy women? Is there a role here for treatment of GSM with that?
Well, we use a lot of tibolone in Malaysia, and it has got an androgenic effect, which actually helps with libido, urinary symptoms, vaginal health. But again, it is, so yes, definitely it has got a role. I mean, there have been very good studies with vaginal health and tibolone. But again, I think I would like to add the fact that it is still a holistic view, and we have to take everything else into consideration along with tibolone to actually help that woman.
Another question about, I think this is a synthetic estrogen cream, Promestrian. Are you familiar with that or have any opinion on it? Okay. I'm not either. Okay, and then let's see. Hyaluronic acid seems to be very helpful. Should we consider as long-term use in women with symptoms?
Hyaluronic acid has become the in thing for eye treatment, knee problems. Basically, it traps that moisture, keeps it in. I don't see any harm with it. It is a moisture. It's a moisturizer that can be used. But to go back to what Professor Celine Bouchard said, it's estrogen that's still better. And I'm sure she's going to agree with me about that. But if someone does not want to use estrogen or cannot use estrogen, then a vaginal moisturizer with hyaluronic acid would be a great option.
I agree with you. We will not recuperate the lamina propria. That's the main point. We will not have the component of the vagina healthy. It's just lubricate, hydration and moisturizing.
There is a mention in the talk about waxing and trimming of pubic hair. Does this help vulvar symptoms? Does it harm vulva-vaginal symptoms? What are your thoughts on that?
Well, I think it also depends on, so a lot of women actually wax, and because of that, it actually takes away that initial, that surface skin, and that sometimes over a period of time becomes thinner and thinner and can become very, very sensitive. It also depends on other lifestyle changes that, choices that she's had. So with repeated waxing, we do find that may become a problem as they get older. So in that sense, trimming would probably be a better option, or shaving where the root of the hair is actually not taken off. So again, changes from woman to woman, and again, trying to individualize that therapy, see what's actually going on with her, actually plays a very important role.
And there's another interesting question about at the recent Menopause Congress, one of the professors mentioned they weren't certain why coffee might be associated with GSM. Any information from the two of you on any new data coming to light on coffee, caffeine, those sorts of things?
No.
Yeah.
I think that
still love my
it's more
coffee.
the health side. It's more related to the health style.
Yeah.
Don't drink coffee. It's always there. Don't drink alcohol. Don't drink coffee.
Right, this is a good one. It's more on complementary medicine. So there's an herbal remedy recognized to increase vaginal sensitivity called alligator pepper. Mechanism not entirely known. Any thoughts on this one? Yeah.
No.
We had in Canada, a cream that you put on the arthritis, and it was burning. So they said you put that on the clitoris, and they said you have a better orgasm. It's just that you feel your clitoris. You have not a better orgasm. You feel the clitoris because it's burning. So it's not very popular. I don't know this kind of alligator cream.
Yeah, me neither. Last question for you guys. We talked about breast cancer aromatase inhibitors. Any other considerations for vaginal estrogen therapy in women with other cancers, thyroid, endometrial, history, etc.?
I will say no, because it's very local. I will say no. It's just the breast cancer with the inhibitor, aromatase inhibitor. That's the major point, because if you you are at 0 in estradiol level in your blood with the aromatase inhibitor, and you can increase up to 3 or 4 picogram. It's just a little, but you are not. You cannot be at 0. It's just the only point is the aromatase inhibitor. I will not be scared of the other cancer because it's local.
Yeah, I would be comfortable too.
Okay. Thank you both so much for your time today. This is a very engaging talk. I've got a few more slides to go over as we close out these last 5 minutes. So for those of you still listening, please visit the International Menopause Society website to find out more with many local and regional societies who are members of CAMS. And we have a monthly live event and extensive library of educational resources for those looking for specific topics to learn. And a plug here for the 20th World Congress on Menopause will be held in Brazil this year, September 30th to October 3rd. So please head to the website if you're interested in attending and register for this fall. Thank you all for being here today. It was a great talk and a great subject to learn about, and hopefully many feel more comfortable now after this session as they see patients with GSM. Thanks, everyone.
Thank you, Dr. Allen. Thank you, Dr. Allen. Thank you, Dr.
Thank you.
Damodaran.
Absolutely. Have a great day, guys.
Thank
For you too. Bye-bye.
Bye.